Hi, secular fam. Um, Happy Friday. I am a little bit distracted today because, as I was saying earlier, I'm in Flagstaff. I am in the cool pines. I think it's about 80 degrees right now. And tomorrow I am going to be tabling at Pride in the Pines starting at 11 o'clock at the Thorpe Park softball fields. I hope to see everybody there. And if you are aware of a fun action or activity that's happening this weekend, please feel free to put it in the chat. Remember, when you do put things in the chat, you want to switch the little blue button on the bottom from host and panelists to everyone. So, but for today we are talking about something that is very timely, unfortunately. Dr. Dr. Adam Ratner is a pediatric infectious disease physician based in New York City. In addition to practicing medicine, Dr. Ratner directs an active research group and teaches students, residents, and other trainees. His work has appeared in the New England Journal of Medicine, PNAS, Pediatrics, and other venues. Currently, Dr. Ratner is a member of the Committee on Infectious Diseases of the American Academy of Pediatrics, edits a major textbook of pediatric infectious diseases, and serves on numerous advisory and editorial boards. He speaks widely in both academic settings and news outlets on topics relevant to vaccination and infections in childhood, and is the author of the book Booster Shots, The Urgent Lessons of Measles and the Uncertain Future of Children's Health. Wow, that is quite the resume. Is there anything that I missed that you'd like to add?
No, thank you. I'm really grateful to be here. So thanks so much.
And I know you're going to be sharing your screen, so I'll just
Mhm.
turn it over to you. And like I said, I will keep an eye on the questions. But for those of you who are here today, Dr. Ratner will be taking the questions at the end. So I'll keep an eye out, but just be patient.
Great. Thanks so much. I'm very grateful to be here today and to get to talk to all of you about a topic that is, as you said, unfortunately very timely these days. I'm going to be talking about the return of measles and other vaccine preventable diseases. I always do a disclosure slide at the beginning. I'm speaking as an individual, not as a representative of any institution. I don't have any financial conflicts of interest. I do lots of committee and editorial work, the bulk of which is done with the American Academy of Pediatrics, but I work with some other groups as well. And the book that Janine mentioned is Booster Shots, and I get royalties from that. Okay, so measles has been in the news recently, for what feels like forever now, but really a lot just in the past 6 months or so. And I think it's worth thinking about how the story of measles is being presented, and how we can think about this, evolving issue that is facing us. And so it's June in 2025, and much of the story of measles today is wrapped up in the large outbreak that's taking place in West Texas and surrounding states. The most recent update from there is that outbreak has about 750 cases so far. That is in the context of, as of this morning, about 1,200 cases in the United States so far in 2025, and that's a lot of cases. I'll put that into context of the last few years soon. It's, when you look at the age breakdown of these cases, it tends to be a disease of childhood, and specifically of unimmunized children. About 2/3 of the cases so far are in people under 19 years of age or younger, and the vast majority of the cases that have been reported, and essentially all of the hospitalizations, have happened in people who've not received the measles vaccine. There have been nearly 150 hospitalizations so far, about 12% of the total cases, and tragically 3 deaths, 2 in previously well children who live in the West Texas area, and one in an unimmunized adult in New Mexico, just over the border from Gaines County. And the other thing that we've seen with how the measles outbreak, especially that particular outbreak, has been presented recently is in the setting of just a tremendous amount of misinformation and disinformation, much of which has been coming from now the highest levels of our government. From the very beginning of the outbreaks, this is an article from February. We were sort of gaslit by someone saying that the measles outbreaks are not unusual. That is not the case. There was the idea floated that the outbreak is the result of poor diet and health. When the first child, a 6-year-old girl, died in West Texas, her family was exploited by Kennedy's anti-vaccine group. And there's if you haven't seen it, don't watch it. A horrible video of an interview of the parents done by Children's Health Defense. And the other thing is that misinformation that we've seen has had real medical consequences for some children. There's been this idea, this promotion of vitamin A as a way of preventing measles. It does not work for that. But what it does do, if parents give their kids high doses of vitamin A over a long time, is it can cause liver failure. And a number of kids have presented to the Children's Hospital in Lubbock with vitamin A toxicity and pretty serious liver failure. So I want to think about measles in general and how it can be sort of a proxy, another way of looking at the many challenges that we're facing now. And you can think about measles from a bunch of different points of view. The most reductionist one, I think the simplest one, is that measles is caused by a virus, the measles virus. And when I lecture medical students about measles, this is where we start. We start with the fact that measles is a virus. It has an RNA genome, which makes it like a lot of other respiratory viruses like flu and COVID. It spreads very efficiently through the air. It infects humans only. It does not have an animal reservoir. It's incredibly contagious. It has an R naught, which is a value that quantifies roughly how contagious a particular virus is. It has an R naught of somewhere in the range of 12 to 18. By comparison, in a typical year, flu has an R naught of about 1 to 2. COVID at the beginning of the pandemic had an R naught of about 3, and measles is at least 4 times that. And measles came to it now circulates only in humans, but when it first came into humans, it came probably from cattle, probably in the 6th century BC. And how we know that is a fascinating story that I'm not going to get into today, but I do discuss in the book. And so, like influenza, like COVID, it is something that we have experienced as a result of our interactions with animals. So that's measles as a virus. We can talk about that. There's interesting biology in there, but it doesn't really tell you much about how we as humans experience measles. So you can also think about measles as a disease that individuals get. And this is something else I talk to medical students and residents about when I teach them. This is an image of a child with measles from the American Academy of Pediatrics. There's a typical cluster of symptoms that we see. Kids with measles have fever. They have what we call the 3 C's: cough, coryza, which is just a fancy word for snotty nose. I think they use that with measles so that we can have the 3 C's, and conjunctivitis, so very bright red eyes. And then this rash, which you can see here, that's very typical of measles. There's a timeline, sort of a standard chronicity to how measles progresses, a child gets exposed. There's a roughly 2-week period after exposure with no symptoms at all. A couple of days after that with a prodrome, which basically means some non-specific symptoms. So fever, cough, coryza, conjunctivitis, but not the rash that really tells you that it's measles. And then about a week of rash. It starts on the face and neck, spreads down onto the trunk and the arms and legs, and then goes away over time. The reason that I show you this timeline, the reason that we're talking about it is that kids are contagious in this area here from about 4 days before the rash starts until about 4 days after the rash has started. And those 4 days before end up being really important. One of the reasons that measles is so very contagious in populations is that kids spread a lot of virus even before they have the rash that tells you, hey, this kid has measles. And so, it's a time when parents may be bringing their child to the doctor or to an emergency room or something like that. There can be spread in those places, and it's one of the reasons that measles outbreaks can really get out of control. For most kids, that's the timeline, and they get better pretty quickly after the roughly week of rash. But there are complications of measles, some of which are severe, and that's one of the reasons that we take measles outbreaks so seriously. Almost 10% of kids develop diarrhea. About 5% of kids with measles will develop pneumonia. That's the number one reason for hospitalization for kids with measles. In recent outbreaks, including the one in West Texas, it's been more like 10% of kids who've developed pneumonia. And then there are the rarer but worse side effects. A little under 1% of children will develop seizures. 2 in 1,000 kids with measles will develop encephalitis, which is swelling of the brain, and that can result in hearing loss that can be permanent, blindness that can be permanent, and other really life-altering complications. And then about 2 in 1,000 kids with measles will die. Um, and that sounds like a low number. And for any particular child, that is a low number. The odds of any child who gets measles dying from measles is low, but it's not zero. And on a population level, it's not surprising that we've had 1,200 cases in the US so far this year, and we've had 3 deaths. That sort of lines up with what we think in terms of the rate of these complications. Okay, so measles is a virus. Measles is a disease that affects individuals, but we also think about measles in terms of how it affects populations. It's more than just single people having diseases. It impacts populations, and it does so unequally. And I think of all of the things that I learned researching this book about measles, this was the one that really stuck with me. Like I knew that there were inequities in how populations experienced measles, but I didn't realize how pervasive that was or how far back in time that story went. Um, Much of what we know about measles comes from studies in island populations in the 1800s, and I'll talk about some of those. But basically, around that time, there were two ways that populations were experiencing measles. In large cities in Europe, where measles had been circulating for a long time, it had become a childhood disease. It basically everyone got measles at some point in life, usually during childhood. People, you would have most kids get measles and get better. Some kids would die of it, but those who didn't die would grow up, become adults who had immunity to measles. They would have kids, or other kids would move into the population that would be susceptible. You would have an accumulation of susceptible people that would develop measles. And so you would get this sort of cyclical thing where you had some years with more cases, some years with less cases, but it stuck around in the population. In contrast, if you have small populations that are isolated from those large, cities, those large population centers, you had something that looked more like this or this, where there would be introduction of measles, a lot of cases all at once, everyone would get sick all at the same time, and then measles would run out of people to infect, and it might be many years before it re-entered that population and caused another outbreak. And that led to cities and islands experiencing measles very differently. And so the first story that I want to tell you is about these islands, the Faroe Islands. So this is just for orientation: Iceland here, Norway here, Scotland here. The Faroes are sort of at the midpoint among those. So you don't just end up in the Faroes; you have to want to be there. It's The Faroes are a collection of about 18 islands. Some of them are very close together, some of them are a little more spaced apart. And one of the important things is that the in between these islands, there are very fast moving currents, and it is hard to get from island to island. This is what the cliffs of one of those islands looked like in the late 19th century, which is kind of the time period that we're talking about. So it was no joke to get sort of down the cliffs, across the water, and to another island. So some of those islands were quite isolated despite being physically close to others. So what happened was, in 1846, there was an outbreak of measles on the Faroe Islands for the first time in at least 65 years. So basically, no one who had lived on the island, no one who was living on the islands at the time, or the very few people there who were over 65, might have experienced measles before. But essentially, the entire population of the Faroes was not immune to measles, was susceptible. The Faroes were under the economic control of Denmark. They were a colony of Denmark, and Denmark really kept a tight lid on what the Faroes could do. All of the commerce in the Faroes had to go through this city called Tórshavn right here, and it all went by boat between Tórshavn and Copenhagen. And so no other boats were allowed to land on the Faroes. There was no other trade with anywhere else. And the Faroes were quite impoverished at the time, as a result of policy from Copenhagen. So the way that this outbreak started was that a man who lived in Tórshavn went to Copenhagen on business, got exposed to measles, came back to the Faroes. There were a couple of additional cases, and the two doctors who lived on the Faroes realized that they had an issue. So, and that it was likely that measles was going to spread. So they contacted the health department in Copenhagen. They asked for help, and the health department in Copenhagen sent their version of the CDC, which in this case was literally two medical students, one of whom was this guy. So this is Peter Panum. He and a fellow medical student, Albert Manicus, went to the Faroes to try to help out, and they had some training, but there wasn't a lot that they could do for people with measles. But what they could do was gather information. And so what they learned during that outbreak is really the foundation for everything that we understand about measles today. Panem was not thrilled about getting sent to the Faroe Islands. He kept a detailed journal. He writes about at the beginning about how, essentially how it's deep silence reigns here. There's the murmuring of the spring of the streams and the call of birds. It's monotonous, and it's the somber aspect of the landscape. It was basically like a letter from camp home being like, "How did I end up here? Get me out of here." Um, so the approach that Panem took was very atypical for the time. Like usually what a doctor would do if called to see someone with measles is give them reassurance, make sure that they stay out of the light because the light would hurt people's eyes, and just to try to nurse them back to health. He went from village to village to village, wrote down everyone who had measles, what the date that their first case started, who the first case in the village was, who they had been in contact with, all of this information that was not standardly collected at the time. And so you can see in this map that he drew, this is Torshavn, where the first case occurred on this little island nearby. The first case there was on May 13th. In this town near Torshavn, the first case was on May 3rd. And he did that for the entire set of islands. And what he was able to figure out as a result of that were fundamental things about measles that we still, rely on today. He figured out the incubation period, so the amount of time between exposure and the first symptoms. He figured out that only person-to-person transmission made sense. There was this idea still at the time about miasma as the way that diseases spread. People knew that measles could spread from person to person, but it was categorized as a contagious miasmatic disease because they thought that both things were important. In this outbreak, it was very clear that the only thing that was happening was person to person transmission. He figured out the time of maximum contagiousness right around when the rash started, which was not what people thought, because your skin peels sort of at the end of the measles rash, and everyone thought that measles was in the skin because the rash was there. And so you were contagious when your skin was peeling because it was those little pieces of skin that did it. And so he figured out all of these things, wrote them up in a report, drew this map, and went back to Copenhagen. And what he brought them was, much more than, hey, I went to the Faroes, it's crazy how many people got infected. Like in the population of 7,000 or so, there were about 6,000 cases. There were about 180 deaths, which is about 10 times the case fatality rate that we have now. But the end of his report that he gave to them was really incredible. Like basically what he said to the folks at the Department of Health in Copenhagen was, hey, we can provide medical care, but actually if you go somewhere and you study the people who are sick and you understand the conditions in the place that you go, and you look at what he called the geography of disease, which basically meant not just, mapping where disease went, although he did mean that, but also everything that he did with dates and exposures and stuff. He thought that you can really understand a disease, and he said the special study of which will soon be an independent science. And essentially what he was talking about was the invention of epidemiology, which is not bad for a medical student who was sent to somewhere where he didn't want to be. Um, The only other island outbreak that I want to tell you about happened in Fiji, and it was a little bit later. It was in the mid 1870s. And this also is a story of colonialism and disease and the impact of these expanding empires in the 1800s on the people of island nations. So this guy is Kakubau, who was the king of Fiji. In early 1875, Fiji became part of the British Empire. It was only marginally by choice. It was, papers were signed and it wasn't a military takeover, but basically they were forced to do this. And after that happened, Kakobau went to Australia, also a British colony. He went to Sydney to finalize paperwork and to talk to the regional leaders there. And unfortunately, Eastern Australia was having a huge measles outbreak at the time. As far as we know, no one on Fiji had ever had measles before this. Kakobau got sick. He went back home along with other people in his party. Everyone was very interested in coming to see him after he got back. They wanted to hear what happened in Sydney. And so there was this big gathering of people from all over the Fijian Islands when he got home. And then people went back to their local villages. And then, a week later or 2 weeks later, measles just exploded in Fiji. And essentially, everyone got sick, adults, children, elderly folks, all at the same time. And society essentially collapsed during that time. The death toll was thought to be about a quarter to a third of the Fijian population. And that's in part because people died from measles, but also in part because there was no one to nurse the sick. There was no one to cook food. There was no one to do anything to help anyone else. So, I mean, children died because their parents were incapacitated. It was a horrible, horrible situation. Um, and that was, that was the result of colonialism and this sort of all at once exposure of this, what some authors would call, a virgin soil epidemic, but really was a direct result of the colonial actions of the British. Um, so I said that things were different in cities at the time, and that's true, but there were pretty huge inequities in cities also. So this is a picture of tenements in Glasgow in the early 1900s. And so what you can see is that there are lots and lots of apartments. There are, single entrances where called closes where people go to their individual apartments. And this guy named James Halliday was a public health official in Glasgow at the time. And he realized that kids died more often of measles if they lived in tenements than if they lived in this other area called housing scheme areas. And basically the housing scheme was either single family houses or dual family houses, but it was much less dense housing than the tenements. And so he did a sort of Panem-like epidemiologic investigation. He went to the tenements, he went from door to door, he assessed how many kids were there, how they lived, where the kids played, all of these things. And what he found, in retrospect seems obvious, but really was incredible. So he found that the tenements were different from the housing scheme areas, that there were these shared entrances that were used as play areas by kids. So kids were exposed to everyone going in and out of the building. They lived in densely packed, not so well ventilated places. And as a result, children who lived in tenements were exposed to measles at earlier ages. And all of the complications that I listed for you before of measles are worse if you get them at a younger age. And what he found in his set of data was that mortality in the kids under age 2 was 10 to 20 fold greater than it was for kids age 5 or 6, which was about the age that people in the housing scheme areas tended to get measles. And so poverty by way of architecture. So like the kids who came from poorer families died more often from measles, but the sort of the mechanism for that happening was the architecture of where they lived. And we saw that in the city where I live. So this is an image from How the Other Half Lives, which was a work of journalism by Jacob Rees, this guy in the late 1800s. And basically what he did was go to the New York City tenements and try to document what was going on there for the people outside the tenements in New York City who had no understanding of how people lived. And so this is a schoolroom in the tenements where kids were kind of packed in with a furnace in the back there. This is very much like the tenements in Scotland where the kids played in the entrance area. You have kids playing in this sort of poorly ventilated place where people are walking through. Um, and he spoke specifically about measles. He said, yeah, the measles, which is ordinarily a harmless disease, is a good example of how the tenements affect health. It's, tread it ever so lightly on the avenues, meaning where the rich people live. In the tenements, it kills right and left. And he described seeing families that lost multiple children in the course of a single epidemic in New York City, and not that long ago. And in contrast, at about the same time, this is from the 1920s. This is a cartoon from a magazine in London with a little child saying, seeing his mother go into the room to bring something to his sister who had the measles, and he says, "Mommy, may I have the measles when Violet's finished with them?" Like it's something to be envied to have the measles. So on the one hand, you have kids in the tenement literally dying in droves of measles, and on the other hand, you have people who dress like this and live in homes, where the child envies the other child with the measles. And even later than that, and even among people with considerable resources, there were sporadic tragedies with measles. And so this is Roald Dahl, who wrote the BFG. He also wrote Charlie and the Chocolate Factory. The reason that I have the BFG up here is that this is the book that he dedicated to his daughter Olivia. Olivia was 7 when she developed the measles in 1962. The measles vaccine would be licensed in 1963. And the family thought that she was fine, that she was just having a normal course of the measles, and she developed what was probably measles encephalitis and died. And so even being an author, even being a middle class person in a vibrant city does not protect kids from dying from the measles. Okay, so measles is a virus. Measles affects individuals. Measles affects populations, and it does not affect them evenly. And that's all true, but that was all stuff that we couldn't do anything about until about the 1960s, which was when the first measles vaccines were licensed. The idea of measles vaccination dates back further than that. So the first real attempt was in the 1700s. This guy, Francis Home, um, tried to use inoculation in the same way that people used to inoculate against smallpox, where they would take material from smallpox lesions and give them to, like, inject them into people who didn't have smallpox to try to protect them. He essentially tried to do the same thing with measles. He claimed it worked in some cases. It was never clear. A pediatrician in New York City in the 1920s tried a very similar thing where he took snot from kids with the measles and gave it to young children who probably still had some immunity from maternal antibody, to try to give them long-term protection. Again, it may have worked, but it wasn't exactly a scalable solution. What ended up working was exactly what worked for the polio virus. So this guy is John Enders. He was a scientist at Harvard who really laid the foundation for the polio virus vaccine. He developed technology that let people grow poliovirus in cultured cells in the lab. So you could basically grow as much of it as you wanted, and then you could kill it to make a vaccine, or you could attenuate it by passaging it in different kinds of cells to make a different kind of vaccine. And once that worked, and once he had won a Nobel Prize for helping develop the polio vaccine, he turned his attention back to the thing that he was most passionate about, the thing that he started his career working on, which was measles. And he did the exact same thing with measles, figured out how to grow it in the laboratory, and went about making vaccines. And that is what laid the foundation for, in 1963, 2 different measles vaccines getting licensed on the same day. This guy was Luther Terry, who was the Surgeon General. He's the guy who gave us the Surgeon General's report on smoking. So measles was not his most famous thing, but it was an important thing. Um, and he said, yeah, this is a hugely significant advance. It's one of our most serious childhood diseases. We expect to see a very sharp decrease in the coming years. And that was 1963. And it took us a long time to make the progress that we've made, because the story of the measles vaccine is about a technical triumph, but it's also a story about public policy and about lessons that we learned along the way. So when you zoom way out and you think about the measles vaccine, this looks like a public health triumph, and it is. So measles vaccine was introduced in 1960. This is estimate of number of cases of measles in the United States, about 500,000 a year. Before that, it goes down, it goes up, and then it drops, and you get to endemic measles elimination, which doesn't mean zero cases, but it does mean no ongoing spread in the US. And this is about 40 years, right? So it's 63 to the year 2000 that it took us to do that. And even after 2000, you don't get to zero in terms of cases. You have little ups and downs, but it looks pretty good on here. But a lot happened in here. Like there were times when it looked like we were going out of control with measles, that it wasn't going to get to elimination. And at each of these points, we learned things that were crucial to helping us get to endemic measles elimination. I want to tell you an outbreak story from 1970. So that was one of these little peaks here. Um, the city of Texarkana straddles the Texas and Arkansas border. This is a picture from State Line Avenue in Texarkana. Texas to your left, Arkansas to your right. The local government building is bisected by the state line, so half of the building is in each state. There was a measles outbreak that started in June of 1970. It kind of smoldered along, and then when kids went back to school, it really took off. And the city is interesting because about 2/3 of the population lived on the Texas side of State Line Avenue, about a third lived on the Arkansas side. The two sides of the city had very different policies about vaccination because kids were zoned for school based on which side of State Line Avenue they lived on. But there was tons of mixing. Like you would go to the movie theater, or you might go to church on the other side of State Line Avenue. But essentially, the kids who lived on the Texas side, where there were no school mandates and no vaccination drive, about 60% of them were immune to measles by age 10. And that was the result of catching measles. On the Arkansas side, because there were school mandates, because there were vaccination drives funded by the local government, about 95% of kids were immune to measles. And that made a big difference. So this is a map of where the cases were during that outbreak. And what came out, which is not a surprise to us now, but was a little surprising then, was that more than 95% of cases were on the Texas side of the map. And this was a stark demonstration that these were not different kids. These were not, the families lived in the same city. These were not people who behaved differently. This was a line that was drawn by policy, by how you felt about school mandates and about government financing of vaccination drives. And it made a big difference in the health of kids. So what we learned from Texarkana was school mandates work, government-funded immunization drives work, policy has a direct effect on children's health, and geography like that is a powerful tool. We knew that from Peter Panum. You knew that already, but it was a reminder. And we still see Texarkana is still fascinating. There was the exact same thing that happened with with Medicaid expansion as part of the Affordable Care Act, where Arkansas took the Medicaid expansion, Texas didn't, and what happened was there was this incredible divide in preventable deaths. Okay, so we had those ups and downs. These are those two other peaks other than the 1970s one. Huge outbreaks in large cities in the late 90s, the late 80s, early 90s, Chicago, New York City, Philadelphia, Houston. What we learned from that was that 2 doses of MMR, not 1, were required. And what we really figured out largely from Chicago and New York was that there were all of these kids who weren't getting vaccinated, in part because their families couldn't pay for it, and in part because the way that public health clinics were set up was ridiculous. Like they would be open from 10 a.m. to 2 p.m. in the middle of a workday or something like that. And so both an expansion of local public health and the development of the Vaccines for Children program which made sure that all kids, whether they had private insurance or public insurance or no insurance, were would be eligible for vaccination. They would have their vaccination covered, and those interventions were really what got us to 2002 elimination of measles in the U.S. And we were great for a few years, and then the wheels started to come off the bus. And this is largely a story about the growth of the anti-vaccine movement. So before I do that, what we've learned from the past 60 years of measles vaccination in the US is that you can get to elimination. The measles vaccine is incredible, but you need really high rates of vaccination coverage. You need school mandates. You do not get over 95% without school mandates. We've tried that. You need 2 doses of MMR, not one. You need well-functioning state and local health departments, and you need stable funding for vaccines. And the issue that we've had since 2000 is that anti-vaccine misinformation and disinformation threatens every piece of that progress. So that is why the story of the measles vaccine is also a story about trust. Um, and this really hit home for me in 2018 and 2019. So I work in New York City. I grew up in New York City. And I had gone through the bulk of my pediatric training and my infectious disease training. I saw a couple of cases of measles, a couple of returning travelers with measles, a small cluster of measles in northern Manhattan a few years ago. But then all of a sudden in 2018, the fall of 2018, I saw my first measles case in a long time around here. And then by the time we got to March or April of 2019, we were seeing multiple kids in the hospital every day with measles, some of whom were really sick, some of whom needed to be in the intensive care unit, some of whom needed to be on ventilators. We were fortunate that no one died. But it really was a perspective altering thing for me, and it was the result of vaccine hesitancy in a community that was directly targeted by the anti-vaccine movement. So much like the West Texas outbreak, the vast majority of kids who developed measles during the 2018-2019 measles outbreak were either unvaccinated or unknown, and the vast majority of the unknowns were likely unvaccinated. There were emergency declarations and schools that were closed because they refused to comply with mandatory vaccination from the public health department, and there was incredibly sophisticated, highly culturally targeted anti-vaccine misinformation. This outbreak was centered in Brooklyn. It was centered specifically in a couple of Orthodox Jewish communities. These are communities that, for the most part, did not get their health information from the internet. So this was not a Facebook and Twitter outbreak. This was the anti-vaccine movement putting together a glossy pamphlet in both Hebrew and English, distributing it at supermarkets, putting it under people's doors. It had, arguments supposedly from the Torah about how people shouldn't vaccinate their children. There were no vaccines at the time that the Torah was written. Obviously, the Torah does not say anything about not vaccinating your children. They set up hotlines for parents to call that were really just, anti-vaccine information. And there was very provocative messaging about how there was, monkey, rat, and pig DNA in the measles vaccines, which is insane, but was designed to enrage and frighten the communities in Brooklyn. And so what we ended up seeing was that in 2019, we had over 1,000 cases over 1,200 cases in the U.S. that year, largely driven by the outbreak in Brooklyn and a linked outbreak in Rockland County, which is north of New York City. This is where we are as of this morning. We're at 12/14, so we're almost caught up with 2019. And the other thing that was perspective shifting for me was usually the proxy that we use for thinking about whether a community is at risk of a measles outbreak is what is the two-dose MMR coverage, measles, mumps, rubella vaccine coverage by age 5. And if you look back to 2018, 2019, nationally in the US, we were over 95%, just barely, but we were there. In New York City, we were at 98%. I would not have given that a second thought. I didn't think that we were at risk of a measles outbreak here. But the thing that changed was that Williamsburg, which is where the outbreak was centered, had a vaccination rate of under 80%. And that is a recipe for measles, even though the city as a whole had a much higher rate. And so the result of this is that we had that outbreak. We have the outbreak in West Texas now. We are in real danger of losing measles elimination status in the United States. This modeling study that just came out a couple of weeks ago gives us about an 83% chance of losing measles elimination status in the next 10 to 20 years. And if we don't maintain current levels of immunization, if they drop even a little, that becomes essentially 100% likely, and it happens faster and faster. And we still have that kind of heterogeneity in New York City. This is zip code level data for measles vaccination. We have some zip codes with very high levels of vaccination, some zip codes, all of Staten Island, for example, with very low levels of vaccination. And that's a story that has played out across the country. And the issue that we really have is that measles vaccination in general, has become about individualism and political division in a way that this is something that should never have been politicized. And it has put us in a very, very bad place. Some of this came out of COVID. We know this, that there were sharp divisions during COVID in who accepted or did not accept COVID vaccination. That translated into excess death rates among, largely in Republican counties, where people had lower vaccination rates. In Texas, in January of this year, there were bills filed to try to weaken school vaccine mandates. And that was really before the outbreak in West Texas really got going. But even as recently as April, that push for weakening vaccine mandates is still going on in Texas. And there's been this split in how parents feel about vaccines, about vaccination requirements in schools, where especially among Republican parents, there has been a drop in acceptance of school mandates. This used to not be a political issue, and it now very much is. And of course, we have everything that is going on with HHS now. Robert F. Kennedy Jr. Has essentially fired everyone who was on the advisory committee on immunization practices. This is, I think, likely to disrupt availability of vaccines. And there's a good editorial from the folks who were fired that was published just a couple of days ago, telling us essentially what danger we are in. And I bring this up because measles is our most contagious disease, which means it comes first, and it is a harbinger of other things that are going to come. Outside the US, where places where measles has not been eliminated, there's still this massive global burden. So there are about 10 million cases of measles a year, more than 100,000 deaths, which are mostly in kids under age 5. in the US, we have that heterogeneity that I talked about at the state level. Even if you look at the nationwide level, we've gone from that 95.2 before the pandemic to we're under 93% and falling. If you look at individual states, you've got a lot of states that are this bright orange color, which are less than 90%. And then if you look at the level of counties, what you see is that even in states that may have relatively okay looking vaccination rates, like Texas, which was at about 93 or 94% at the beginning of the year, you've got areas like West Texas where the rates are much lower. And that's where we're seeing these outbreaks concentrate. And it's not just measles. We're seeing surges in other vaccine preventable diseases like whooping cough. The Louisiana DOH said they would no longer promote mass vaccination in February. By April, they had 2 infants who had died of whooping cough. There were another 2 who died in Kentucky earlier this year. This is a vaccine preventable disease. And so I don't want to leave on a negative note, but I think that we are truly in a precarious situation. And I want to just end with my last 2 slides talking about what is at stake, which is that, you know, childhood vaccines save lives. So the best estimate we have over the past 50 years is that about 150 million lives worldwide have been saved by vaccines. About 93 million of those were from the measles vaccine. This is a massive public health and economic benefit, and it's a humanitarian benefit. Um, if you care more about the US, the estimate between when vaccines for children started and 2023 was prevention of 500 million illnesses in the US, more than 1 million deaths, $3 trillion in savings. So vaccines really, really matter, and they are really under threat. And I think that American families are in danger of ending up in a situation that they do not want to be in. And I will end with an image, which is my grandmother's vaccination card. So this is from almost 100 years ago. This is May of 1930, when she was 1 year old. And it's a vaccination card, but it's only diphtheria protection because that was the only required vaccine in the New York City public schools at the time. And her parents, I can imagine. I never knew her parents, but her parents, I imagine, taking her for these vaccines and being so excited that diphtheria, which is certainly something that they saw kill other children, would be something that they wouldn't have to worry about. And I don't want it to be that kind of knowledge that we need in the US to get us back to the place where we were, or the place where we need to be. But I worry that is where we're headed. I thank you all very much for listening, and I'm delighted to take any questions. Thank you.
Well, this was a really, really interesting discussion, and I really enjoyed too your use of visuals. I'm a visual learner, and so the 2 things together really kind of helped me. There is the first question here in the chat comes from Philip, and he says, "Why does the measles vaccine last for a lifetime, whereas one must receive an annual booster for other viruses like flu and COVID? Does the virus that causes measles not mutate as rapidly as the flu and COVID viruses?"
Great. Yeah, what a fun question. Thank you. You're right. The measles vaccine is crazy, right? Because we're using essentially the exact same vaccine that was developed in the 60s. And why can't we do that for flu and COVID? You're exactly right. It has to do with mutation rates. We see a very different flu virus circulating every year, and it that really matters. It changes enough that you need a new vaccine formulation every year. It doesn't mean you have no carryover of immunity from year to year, but it does mean that you need that different shot every year. Same thing with COVID. The biggest difference is probably whether you've gotten your primary series or not. That provides you really important protection, but optimal protection, you really do need protection against the variants that are circulating. And I think that what that has to do with is that the area of the measles virus that is targeted by the vaccine, the thing that you make antibodies against that help protect you, is an area that can't mutate a lot. And we're lucky that that's the case
Hmm.
because measles is crazy contagious.
Hmm. Here's another question. And the question is, on a vaccination card, the MMR vaccine is the one covering measles, correct? Is there a downside to getting another measles vaccine if you don't know for certain that you've had the vaccine?
So yeah, so yes to the first part, which is that the MMR is measles, mumps, rubella, so that should provide protection against all of those. There have been a lot of questions recently with measles circulating about, well, how do I know if I'm immune? I don't remember whether I got one dose or two doses or whatever. It's worth talking to your doctor about. For a lot of people, what doctors are saying is if you don't know, especially if you got vaccinated in that early period between like 63 and 67 when there were two vaccines in use and one of them didn't work as well as the other, a lot of people are saying just get another dose and it's fine. Many adults did not get two doses when they were kids. I didn't get two doses when I was a kid because that recommendation didn't come in until 1990. It's Unless you're a healthcare worker or you're in an area where there's a lot of measles circulating, there's not a routine recommendation to get a second dose. But if you're traveling either to one of those areas or internationally, CDC says yes, do that. I think it's not crazy to do in any case. Like I think if you have doubt about whether you were vaccinated, it would be reasonable to get another dose. It's not a dangerous thing to do.
Okay, that's great. Um, Here's another question from Andrew. To fight the anti-vaxxers, measles and COVID and flu aren't scary. Should we emphasize scarier diseases like polio, whooping cough, and even rabies?
So yeah, I mean I think you're right, and it's interesting what people are scared of and what they're not. I'm scared of measles. Like I think if you look at what's going on in West Texas, we have three people who are dead who didn't have to be dead, and we had 150 hospitalizations. It's a lot. Um, but you're right. I mean I think there are things that are more dramatic. I think people are scared of polio. I think there is still polio in the world. Like if we don't vaccinate our kids, like that is truly a danger, and that is something we haven't had to think about in a long time. Um, so it's very hard for me to know what will get through, and I think one of the things that I learned talking to a lot of vaccine hesitant families, including some of whom had kids hospitalized with vaccine preventable diseases like measles, is there isn't one reason that people are hesitant. There are families who come in and who are like, I got all the other vaccines, but I didn't get the MMR because I had heard about the autism thing. And that's one kind of conversation. There's I was worried about mercury in vaccines. That's a different conversation. There's well, I just think it's too much. I think we're, giving too many vaccines. That's a third kind of conversation. And so I think we need to, and this is on me and other pediatricians and other folks, like, I think we need to be more nuanced in how we approach the discussions.
Yeah. Um, Here's a last question. I'm sorry, I'm just not going to have time for the rest. But curious if insurance companies, because if they're now no longer recommending these certain vaccinations to RFK Jr.'s agency or whatever, will insurance companies, are they changing their policies regarding covering childhood vaccines, or do you think that they will continue?
So I'm really worried about that. And I think there are two components of that, and it's a little different thinking about each of them. So I think that a lot of insurance companies really do look to the ACIP recommendations for what they will cover. I also think that insurance companies are in the business of saving money for themselves, and vaccines are a money saving operation. So if I would never run an insurance company, but if I ran an insurance company, I would still pay for the vaccines that should be recommended. Um, but it's hard to know what they will do. They wouldn't be obligated if if many of those vaccines were no longer, quote unquote recommended. The other issue is the Vaccines for Children program, which actually is directly tied to ACIP recommendations. And so there's a VFC provides the funding for about half of childhood vaccinations that are given in the United States. Like that is a lot of kids. And so that I think is a major concern. And I don't know how that's going to get addressed.
Well, and as a fairly new grandmother, my grandson is about 15 months old now. And
Oh,
thankfully,
yay.
mom and dad are on board with science and vaccines. But just hearing recently about, somebody traveling through an airport of all places,
Yeah.
where people are traveling with their infants and things like that. It's just, it has a different type of concern for me now because, as an adult, somebody who can, take care of myself, make my own decisions, there's a schedule for those babies. And so that's the thing that really worries me when so many people are willing to kind of forego the health and well-being of other citizens of this country because they've read a report 30 years ago or whatever. So the comments in the comment section today at the chat have just been off the hook, very positive. Please be sure to pick up Dr. Ratner's new book. I am really excited to hear that. I want to hear the one story about the correlation of the islands that you were talking about in the outbreak. So I might actually have to pick up a book about vaccines, which
Yay.
I didn't imagine I would do, but it was a really great talk, Dr. Ratner. Thank you so
Thank
much.
you. Thanks so much for having me. And thanks everyone for listening. I really appreciate your time.
Thank you so much. And I hope
Okay.
everybody has a great weekend. Take care. Bye bye.